Imagine for a second holding a microscopic iron inside a human bladder.
Yeah, that's an intense image right off the bat.
Right. And you're tasked with shrinking like a single thread of tissue to exactly 65 degrees Celsius. And you know that a single millimeter of error could permanently damage the patient's renal system.
It's terrifying, honestly, when you really think about it.
It really is. I mean, we hear the phrase routine, minimally invasive outpatient procedure, and it projects this illusion of absolute simplicity for you as the patient. But today, we are stripping away that illusion. Welcome to the deep dive.
Glad to be here for this one.
Yeah, our mission today is to unpack the meticulous, often counterintuitive safety protocols required when doctors operate in, well, one of those anatomically crowded real estates in the human body.
Which is the bladder neck.
Exactly. Applying radiofrequency energy near the bladder neck. We are pulling from a really dense stack of sources today. Clinical reviews, medical device instructions like the Prostiva and Renessa systems, and insurance guidelines.
Yeah, it's a fascinating stack of sources, mostly because it forces us to confront how much complex physics and biochemistry is happening behind the scenes of just a standard Tuesday morning clinic visit.
Totally.
When you apply alternating electrical currents into highly vascular innervated tissue, the protocols we're looking at aren't just recommendations, they are rigid mathematical boundaries keeping the patient safe.
Okay, let's unpack this. Because to understand these boundaries, we really have to establish the physical realities of the bladder neck first. So we're talking about this funnel-like junction where the bladder transitions into the urethra, right?
Right.
Flanked by the external sphincter, the prostate in men, and crucially, those ureteral orifices, the tubes from the kidneys.
Yeah, the neighborhood is incredibly crowded.
It's packed. And you have these highly vascular tissues with varying thermal conductivities just jammed together. So how do these protocols account for wielding basically microwave energy in a space where the margin for error is essentially zero?
Well, the primary way these protocols manage that risk is by strictly defining the biological objective of the energy. Because radiofrequency, or RF energy, is utilized here for two completely diametric purposes.
Okay, meaning they do opposite things.
Exactly. First, you have procedures utilizing devices like the Prostiva system. And the goal there is treating benign prostatic hyperplasia, which is an enlarged prostate.
Right.
They do this by intentionally inducing coagulative necrosis. You actually want to ablate or destroy the excess prostatic tissue that's blocking the urethra.
So the Prostiva protocol is essentially a controlled demolition.
That's a good way to put it.
You're driving the tissue temperature high enough to literally boil the intercellular water and destroy the cells outright.
Precisely. You want cell death. But then you look at devices like the Renessa or SRX systems, which are used to treat female stress urinary incontinence.
Right. Totally different demographic and issue.
Exactly. The goal there isn't tissue destruction at all. It is structural remodeling. So the guidelines mandate achieving subnecrotic temperatures, specifically hovering right at 65 degrees Celsius in the submucosa and endopelvic fascia.
I want to pause on that 65-degree mark.
Okay.
Because that's a highly specific number. Why 65 degrees? What is happening at that exact temperature that, doesn't happen at 60 or 70?
That is the exact threshold where the biochemistry of collagen fundamentally changes.
Oh, really?
Yeah, at 65 degrees, the heat breaks the hydrogen bonds that hold the collagen triple helix together. The cellular scaffold remains completely intact, meaning the cells don't die. But the collagen fibers instantly uncoil, they shorten, and they thicken.
Wow, okay.
So you are creating these localized 200-micron scars. And as those microscopic scars heal over the following months, the tissue shrinks and stabilizes, which is what provides the mechanical support necessary to stop involuntary urinary leaking.
I love that. It's like having a delicate knit sweater that's gotten stretched out around the collar.
Oh, yeah, exactly.
And the Renessa procedure is using a highly calibrated tiny iron to precisely shrink a few specific threads, tightening the collar back up without ever scorching the surrounding fabric.
That is a brilliant way to visualize it. And if we connect this to the bigger picture, you immediately see why the safety protocols for these two procedures are so radically different.
Because the goals are different.
Right. The rules for wielding a sledgehammer do not apply to wielding a tailor's needle, because RF energy isn't like a hot poker you just stick in there.
Right, it's not just a hot piece of metal.
No, it's an alternating electrical current, where the patient's actual tissue acts as the resistor. The friction of the ions oscillating in the tissue is what actually generates the heat.
Which means the patient is an active component of the electrical circuit.
Literally, yes.
And looking at the electrical safety rules for the Prostiva ablation procedure, the demolition one, the grounding requirements are incredibly intense.
Oh, they are strict.
The patient cannot touch any earth metal during the procedure. But the protocol goes even further, strictly dictating that all skin-to-skin contact must be avoided entirely.
Yeah, no legs touching, arms touching.
Right. Medical staff literally have to insert dry gauze between the patient's legs and between their arms and their torso.
And the physics behind that mandate is fascinating. Human sweat is essentially salt water, right? So it is highly conductive. If a patient's bare leg is resting against their other leg, the sweat creates a preferential pathway with lower electrical resistance than the actual grounding pad on their back.
Oh, wow. So the electricity would just go there.
Exactly. The RF current will actively seek out that path of least resistance, arc across the skin-to-skin contact point, and cause severe deep tissue electrical burns.
Ouch.
Yeah. So by using anti-static sheeting and physically isolating the limbs with dry gauze, the protocol forces the current to travel exactly where the physician intends it to go.
Wow. Insulating the patient prevents them from becoming an unintended electrical ground. But that trapped RF energy still has to dissipate safely inside the body as heat.
Right.
And that brings up a massive contradiction I noticed in the guidelines when we look at thermal management.
I think I know which one you're talking about.
The Prostiva protocol, which is the one aiming for coagulative necrosis, explicitly warns against using continuous water irrigation during the procedure.
Yes. The physician is only permitted to use tiny, like 0.5 to 1.0 milliliter flushes of fluid just to clear the optical lens during the initial positioning.
Right, just to see.
Yeah. Once the RF energy is activated, the fluid must be shut off entirely. The device even utilizes a press and release switch for the energy, and the manual forbids holding it down continuously.
Wait, so one protocol says absolutely no continuous water, and the other says constant water is a must. How does a doctor keep that straight when they are just inches apart? I mean, logically, if you are generating ablative heat millimeters away from the sphincter and the ureters, wouldn't a constant flow of cold water be your best safeguard against collateral thermal damage?
You would assume so, yeah. But in the context of ablation, water acts as an unwanted heat sink.
A heat sink?
Right. If you continuously run water over the deployment site, the fluid absorbs the thermal energy way too rapidly, pulling it away from the prostatic tissue.
Oh, I see.
The tissue never reaches that critical temperature required to boil the intracellular water. You end up with an ineffective procedure. You don't get the demolition.
Okay, so Prostiva says absolutely no continuous water because it ruins the demolition. But when you look at the Renessa guidelines for treating incontinence, they dictate the exact opposite.
Right.
They mandate that continuous, sterile, room temperature water must flow transurethrally throughout the entire 60-second energy cycle.
It looks like a contradiction on paper, I know, but it is a masterclass in applied thermodynamics.
How so?
Remember, with Renessa, the goal is to hit exactly 65 degrees in the submucosa, the deeper layer of tissue, to denature that collagen. But if that 65-degree heat radiates outward to the surface mucosa of the urethra, it will cause severe thermal injury.
But so it burned the surface while trying to fix the deep tissue.
Exactly, leading to pain and strictures.
So the water isn't there to cool the target tissue, it's there to protect the non-target tissue.
Exactly. The continuous flow of room temperature water literally acts as a dynamic thermal shield. It actively absorbs the heat radiating to the surface, keeping the delicate mucosal lining well below damage thresholds, all while allowing the deeper tissue to achieve that precise 65-degree collagen remodeling.
Here's where it gets really interesting to me. We're talking about managing microscopic heat waves, thermodynamics, and cellular resistance. But ultimately, a human operator is holding a physical device in their hand.
A very human hand, yes.
Right. And reading the physical deployment instructions in these manuals, it sounds less like standard surgery and more like high-stakes architectural engineering. The physical geometry is just brutally unforgiving.
It has to be. Take the Prostiva device, for example. The safety protocol mandates that the needles must never be deployed until the physician confirms the handpiece is perfectly flush against the urethra.
Perfect physical contact.
Yes, and when they do pull the trigger to deploy the needles, they must pull it firmly and continuously until it hits a hard, automatic mechanical stop.
I assume that mechanical stop is what dictates the exact depth of the needles into the prostate.
Correct. The depth calculation is critical. If the doctor incorrectly estimates the size of the gland and selects the wrong needle length before hitting that mechanical stop, those needles will punch right through the prostatic capsule.
Oh, geez.
They could pierce the bladder neck or, the absolute worst-case scenario, perforate the rectum.
Which is a catastrophic complication for a supposedly routine outpatient visit.
Absolutely. The geometric tolerances are so rigid that the Prostiva device is strictly contraindicated if a patient presents with a median lobe of the prostate that is growing up into the bladder.
Because it changes the shape of everything.
Right. The angles simply will not allow for safe deployment. You cannot safely anchor the device flush against the urethra in that specific anatomical variation.
And the Renesas system has its own highly specific geometric rules, too. To shrink those collagen fibers in the exact right locations, the physician deploys the electrodes, but then the manual dictates they must apply exactly 1/2 pound of traction force.
Yes.
Pulling back on the device using only their index and middle fingers.
And they must maintain that exact 1/2 pound of traction while delivering multiple 60-second cycles of energy. And they have to rotate the probe exactly 30 degrees to the right, then 30 degrees to the left for subsequent cycles.
Just by hand.
They use longitudinal lines printed on the probe's shaft as visual guides.
I have a serious question about that. Relying on a subjective 1/2 pound tactile feel while navigating a rigid probe inside a conscious patient leaves a massive margin for operator error.
Definitely.
How do these guidelines account for varying physician experience levels? Because, like, my 1/2 pound of pull might feel very different from yours.
That is a phenomenal question. And the device manufacturers knew that tactile feedback is inherently subjective. That is why the true safety mechanism is actually rooted in the physics of electrical resistance.
Okay, how does that work?
Before the machine releases a single joule of energy, it continuously measures the tissue impedance. That's the electrical resistance of the tissue physically touching the electrodes.
So the machine is basically verifying the doctor's manual traction.
Yes, exactly. The protocol states that if the tissue impedance reads higher than 300 ohms, the machine will actively prevent energy delivery.
It just won't fire.
Right. Why? Because an impedance spike means the electrodes are not fully seated in the tissue. If the doctor isn't applying enough traction, there is a micro gap between the metal and the submucosa.
And if it fired then?
If the machine fired then, the RF energy would arc across that gap, creating a massive surface burn instead of a controlled submucosal heating. The 300 ohm limit forces the physician to achieve perfect geometric contact before the system even arms itself.
Wow. It's an elegant failsafe. The human feels the traction, but the physics of impedance has the final say.
Exactly.
But what about other modalities? Because our sources also highlight safety protocols for using PVP lasers near the bladder neck for vaporization. Does Othon-based laser have the same geometric failsafes as an RF current?
Lasers introduce a totally different safety paradigm. With a laser, you aren't completing an electrical circuit, right? You're firing highly concentrated light energy.
Right.
The primary geometric safety concern with lasers near the bladder neck is protecting those ureteral orifices, the tiny openings where the kidneys drain into the bladder.
Because if you hit them...
errant laser energy will scar them shut, instantly backing up the kidneys.
So how do you protect a structure that is just, millimeters away from where you are firing a laser?
By physically moving it out of the way.
Moving it. How?
The safety protocol mandates that the physician must keep the bladder relatively full of fluid during the procedure. By hyperinflating the bladder, the physical stretch of the bladder wall literally draws the ureteral orifices back and away.
Oh, wow.
Yeah, it pulls them out of the laser's direct line of sight.
You're stretching the canvas to hide the most delicate details.
Precisely. Furthermore, the geometric rules dictate that if the physician is working at the base of the bladder neck, say at the 5 o'clock and 7 o'clock positions, where the prostate lobes meet, they are required to angle the laser energy laterally, facing outward.
So away from the center.
Yes. They are strictly prohibited from pointing the laser medially toward the center line, because any stray energy would travel straight across the trigone and cause collateral damage to the opposite side.
So every angle of the laser, every ohm of electrical resistance, every milliliter of shielding water is meticulously calculated. But we are leaving out the most unpredictable variable in this entire ecosystem.
The patient's own physiology.
Right. Because the push for minimally invasive treatments means many of these procedures, particularly the Renessa tissue remodeling, are done in an office setting.
Ground OR.
Right. The patient is awake. We aren't dealing with an intubated, perfectly paralyzed body in an operating room.
And that shifts the burden of safety completely. Safety is no longer just about avoiding surgical perforation. It requires aggressively managing a conscious patient's autonomic nervous system and their unpredictable pharmacological reactions.
Yeah, looking at the office anesthesia protocol for Renessa, it requires patients to be pre-medicated with 5 to 10 milligrams of diazepam, which is Valium, and 800 milligrams of ibuprofen, 30 to 60 minutes prior to the procedure.
Right.
Is that just standard pre-medication for procedural anxiety? Or is there a specific physiological interaction with the RF energy we are trying to suppress here?
It is entirely physiological. I mean, while it does manage anxiety, the primary purpose of the heavy diazepam dose is to act as a potent muscle relaxant for the detrusor muscle.
That's the smooth muscle of the bladder wall.
Exactly. If a patient is awake while you apply 65-degree heat and half a pound of traction to their urethra, the bladder's natural reflex is to spasm violently.
Makes sense. It's trying to protect itself.
Right. But a detrusor spasm while deploying an RF needle would destroy the geometric precision we just talked about. It could potentially cause a severe laceration. The diazepam chemically forces the bladder to stay compliant and still.
That makes perfect sense. And then they follow up the systemic medication with a highly localized topical preparation.
Yes. The introitus is prepped with povidone iodine to ensure sterility. Then the physician inserts a 6-inch catheter to drain any residual urine, which, as we mentioned earlier, could act as a heat sink or alter the impedance.
Get the water out of there.
Right. But as they withdraw that catheter, they slowly infuse 5 cc's of 2% xylocaine jelly. They are essentially painting the entire length of the urethra with a topical anesthetic from the inside out.
Which sets the stage for what is arguably the most fascinating manual technique in these sources. The swab and goniometer trick.
Oh, this is a great one.
Explain the mechanics of this, because it sounds like a carpentry technique adapted for urology.
It really is, and it's incredibly clever in its simplicity. The physician takes a cotton swab coated in EMLA cream, which is a powerful topical anesthetic, and inserts it transurethral until the tip rests exactly at the bladder neck.
Okay, so a numbing swab.
Yes, but the primary purpose isn't just numbing. They let the wooden stick of the swab hang naturally outside the body. Then they take a goniometer, which is an instrument used in orthopedics and carpentry to measure exact physical angles, and they measure the resting angle of that specific cotton swab.
Because the urethra isn't a straight pipe.
Yeah.
Every single patient has a slightly different natural curvature based on their pelvic floor tone and individual anatomy.
Exactly. If the physician just forces a rigid RF probe in at a standard angle, they distort the tissue. A 30-degree rotation on a distorted urethra means the electrodes deploy into the wrong tissue plane, missing the target collagen entirely.
Oh, wow. So you have to know their baseline angle.
By measuring the resting angle of the swab, the physician finds the true natural axis of that specific patient's anatomy. They then mimic that exact angle with the RF probe, ensuring the energy is delivered perfectly symmetrically.
Low-tech carpentry solving a high-tech geometric problem. I love it.
Hmm.
But it also highlights the downstream consequences of these protocols.
Yeah, there's always a trade-off.
Because when we look at the clinical trial data for Renessa, the procedure itself was highly successful in terms of tolerability. The mean pain score was like a 1.8 out of 10. The localized numbing, the thermal water shielding, and the goniometer measurements clearly worked. But the safety protocol itself caused the complications.
This is the paradox of pharmacological safety protocols. The systemic medications used to keep the patient safe during the procedure created issues afterward. 2 women in the trials vomited when they attempted to drink water immediately after the procedure, which is a classic adverse reaction to the heavy oral sedation.
And 1 woman experienced temporary urinary retention, meaning she couldn't urinate at all and required a catheter for 24 hours. Why did that happen?
Because of the pharmacokinetic half-life of the diazepam we discussed earlier, we gave her a heavy dose to suppress the detrusor muscle so it wouldn't spasm during the RF delivery.
Right, to keep the geometry safe.
But that medication doesn't instantly wear off when the machine is turned off. Her detrusor muscle remains so profoundly relaxed by the medication that it temporarily lost the ability to contract and expel urine.
Which implies that, you can control the microwave energy down to the exact micron. You can measure the impedance to the precise ohm. But human biology remains the ultimate wild card.
The human element is the one variable an algorithm cannot entirely predict.
So what does this all mean for you listening right now? We have taken quite a journey through the invisible architecture of a supposedly simple outpatient procedure.
We really have.
We unpack the absolute necessity of isolating a patient with dry gauze to control electrical pathways. We explored the thermodynamic contradiction of water, how it ruins a prostate ablation by acting as a heat sink, but is utterly mandatory to shield tissue from thermal burns during incontinence remodeling.
Yep.
We discussed inflating the bladder to hide ureteral orifices from a laser and the sheer geometric gymnastics of measuring a patient's anatomical axis with a cotton swab and a goniometer.
It is a phenomenal amount of cognitive load for the physician to manage simultaneously. And as we look at these sources, it raises a really vital question about the future of surgical intervention.
I'm curious where you're going with this.
Well, we have spent this deep dive detailing how reliant these protocols are on manual human feedback. Trusting a physician's fingers to feel exactly 1/2 pound of traction, or requiring a doctor to visually check a physical goniometer to find a natural anatomical plane. As medical devices become increasingly automated and as robotic platforms take over more of these procedures, will these highly tactile manual safety protocols become lost arts?
Oh, that is the big unknown. Will an automated robotic arm ever truly know what a 1/2 pound of traction actually feels like on varying tissue densities?
Right, or will the human touch and a physician's ability to physically feel the subtle subjective resistance of a patient's unique anatomy always remain the ultimate indispensable safety mechanism that a machine simply cannot replicate?
That is a phenomenal thought to leave on, because the next time you or someone you love hears the word routine at a clinic, you will know exactly the kind of microscopic tightrope your physician is walking in the dark to keep you safe. Thank you for joining us on this deep dive into the hidden physics of healing. Stay curious, and we will catch you next time.